low-income group countries, because in these countries, higher birth weight and heavier babies are developing ROP. So I like this slide. This I especially asked Claire Gilbert and borrowed this slide from her. This summarizes everything. If you look at the top, green, the entire developed world, they have a very low incidence of ROP blindness because they have excellent neonatal care and facilities for taking care of ROP. So that's totally different. We are in the red. So red is the danger, and that is where we also, most of the world is. And here the optimal neonatal care is there. Screening programs are not in place, and we are facing big challenges, and that's how we have the highest rate of blindness. And of course, there are still areas like sub-Saharan and others where we were also a few years back. The babies are perhaps not even surviving, and so they don't have this problem at this time. So the possible reasons for ROP epidemics in these countries are, I think we just got together and had written this a few years back. The basic thing is lack of training among pediatrician nurses to resuscitate these babies and take care of these babies. And poor doctor or nurse ratio, especially. We have a lot of what they call SNCUs in these countries, which are even managed by medical officers. So you can imagine where we are. And the ROP screening and treatment protocols may not be widely followed, or there is a lack of awareness and trained people, those who should take care of that. And this is a big issue which is coming there. So Western screening guidelines, we questioned them, and in fact there was a time, 1,500 grams and 30 weeks or 32 weeks, but we saw that a lot of them are getting missed. This was Anand Vinekar's thesis when he used to be with me, and Subhadra also pointed out, and we could just look at this table. This is something which is happening in our country. So all these yellow studies are from our country, two being from my own center, Sanghi and Tek Chandani. They were with me as fellows, and you can see Subhadra's also, and these are Dressner, you all know, with Michael Tracy and Azuma, and how tiny little babies are developing ROP in those countries. And look at the mean birth weight in our country, and also the period of gestation. So all this led to change in guidelines. So we had finally the guidelines 2 kgs and 34 weeks. Even China has 2 kgs and 32 weeks. And there are other countries like Mexico having 1,750 and 34 weeks. And even in Egypt, it's like 2 kgs and 34 weeks. So I think we have to have country-specific guidelines. That is what is going to help us. And that's how we can screen and find the treatable stage. That's where the whole bottom line is. We are not able to timely find that treatable stage, and otherwise we can have an excellent outcome, around 90% with anti-VEGF lasers or whatever treatment we do. So at this time, the current treatments for ROP include the close monitoring of the nutritional status and the oxygen saturation levels, and that is what is not happening perhaps in many of the countries I mentioned. Peripheral retinal ablation with laser is the standard of, still the standard of care, and anti-VEGFs have come in a big way, and the vitreoretinal surgery for stage 4 and stage 5. So classically, it was a diode laser delivered with LIO and near concurrent fashion. That is the way. And if we were not having diode, we were not even permitted to treat, and 90%. But I think what happened with us, we published a lot on this, our group. Now it is 532 laser, the same laser which is used for other things being used for ROP. So you don't need to acquire special laser. And this works equally well as this has been now taken very well all across. This is one such baby as I treated with 532 laser. So what about anti-VEGFs? Anti-VEGFs in ROPs are slowly becoming more available all over the world, acceptable all over the world, not available, but acceptable. The most would treat these days AROP and ROP in zone 1, first with injections. But the problem is late recurrences and systemic adverse events, are still a concern, especially some of the time we are giving even multiple injections. What about combination of laser and anti-VEGF? We did write a small, like a narrative about, along with Anand. So the laser after anti-VEGF is not required if the vessel reaches zone 3. There's a gray zone here. Some people would treat because they feel more comfortable. Others, they may just watch. Ideal is deferred laser till the vascularization is progressing without any signs of recurrence. That is the way we should be following them. And an anti-VEGF injection will be followed by much less extensive laser in most cases. Especially the problem is, as we are treating a posterior disease, I think we want these vessels to grow further and then treat them. But the problem is may need GA for bigger babies, because like in India, we still treat most of these babies under local anesthesia. The preferred treatment pattern, I would just like to mention here, this is a recent survey. This was an international survey, but it gives you a lot of insight that anti-VEGFs were preferred for AROP, aggressive retinopathy of prematurity, in 64%, and type 1 ROP in 71%. And type 1 posterior also almost 56%, almost like 50-50. So that is the way the big survey, which involves many countries, are giving us what they found out. The majority use laser as first line of treatment for type 1 ROP in anterior zone 2 or type 1 in zone 3. So that is probably in most of the situation. And laser was preferred for rather than anti-VEGF, second anti-VEGF, as a treatment if there was a need because of the recurrence or persistent avascular, peripheral avascular retina. The preferred anti-VEGF in this was also a bevacizumab for ROP. So current surgical approaches are the scleral buckling, lens-sparing vitrectomy, lensectomy, vitrectomy. I think lens-sparing vitrectomy is something which most of us should perform. This is the window. If we perform at 4A, 4B, we can give excellent results. And this is one baby a few years back I have operated. You can see 4B, you just, how nicely it goes back, and you can achieve very good results. Of course, you have problem. We have most of the time this proliferation happening temporally, so you sacrifice the lens. How do you save that lens? I think we proposed nasal lens sparing with all nasal. This has been published. And if you just stick this cannula nasally in the center and do surgery from 2 sides, I think you can achieve all the objectives, save the lens. If you save the lens, I think that's the biggest achievement, and this is what we have been doing for such cases. Stage 5, we all know the problem is that lensectomy, vitrectomy is required, extensive surgery is required, reattachment may be seen in 1/3 of the cases, but functional results are usually poor, and it is frustrating both for the surgeons as well as for the parents. And somehow we don't have to let them go here. If they go here, I think howsoever the big surgeons we are, we can't really do much help to them, and that is what basically we had seen. There's a late presentation of stage 5. This was our group as well as a group in Delhi, which has shown that it was startling that 86 to 89% of the patients in these 2 series were never screened. Can you imagine? And majority were, it was the parents who noted that their child is not seeing. And can you imagine the pediatrician referred none to 8.7%. And this is where it was few years back. We had to create a lot of awareness. And 25 to almost 86% referred by ophthalmologists. That's also late. So in conclusion, higher birth weight babies develop severe ROP in developing and middle income group countries. Screening is the most important to identify treatable ROP. For this, we need country-specific guidelines. Manage all treatable ROP promptly with laser, oblique, anti-VEGFs as per the standard of care. And the lens-sparing vitrectomy for stage 4 is promising, and vitreous surgery has poor outcome in stage 5. Major problem is suboptimal neonatal care and delayed screening because of not having trained manpower or unawareness. Thank you very much.
Thank you so much, Dr. Dogra, for the very nice presentation. What is fascinating in the management of ROP, it's not the anti-VGF or probably even the complex surgeries, but how the multi-speciality collaboration between ophthalmologists and pediatricians has led those kids to be screened and referred to an ophthalmologist in a timely manner, and that is something which at least I, although I don't take care of ROP, but from the other big epidemic of diabetic retinopathy, where we're still struggling to get patients into the ophthalmologist, it's a big chance. So, Dr. Dogra, you have any thoughts on how you worked it out? Your last but one slide showed very few referrals initially. Now, I'm sure it's much more. Maybe even Dr. Subhadra can add from the floor your comments on the multi-speciality collaboration.
Absolutely. In fact, I didn't touch upon that. It starts with the obstetrician. Even the antenatal steroids which are given, they help a lot. And of course, talked about the neonatal care, where, of course, you need to have a very good care, nutritional, oxygen, even otherwise. That's how the countries in green, they have reached that level. And of course, ophthalmic or other care which is there later on. The problem is if the babies are not even sent or there's a lack of trained manpower. Look at special newborn units which are now more than 800 in our country. So we are facing a challenge. We were just talking, Subhadra, me, Dr. Lingam Gopal and Parijat, all of us, that we are facing a epidemic of stage 5 coming from those places. So we need to do much more. We have to involve them, we have to train more people, and we have to also make somehow advocacy at the government level to do more for our country. It's a big country.
But thank you. You are doing